plasma amino acids, urine organic acids, ammonia, lactate, acylcarnitine profile, perhaps CK, and then a urine ketone.
Yeah.
Welcome back to Pediatric. I'm Zach Hodges.
And I'm Alice Shanklin.
Today we have an overview on all things inborn errors of metabolism. That's right, we have glucose metabolism, amino acid, and fatty acid oxidation, with a sprinkling of clinical pearls along the way.
Yes. As a pediatric intensivist, we do, unfortunately, need to know the pathways. Today we have talking with us Dr. Deb Regier. Dr. Regier is the Chief of Genetics and Metabolism at Children's National Hospital in Washington, D.C. Prior to coming over to the clinical side, she was the lipid biochemist. She then went back to med school, came to Children's as a combined pediatric genetics resident, completed her metabolic fellowship at the NIH, and then served for years as Children's National's Medical Genetics Program Director. Dr. Regier's current work in educational outcomes research has led to federal, industrial, and philanthropic support for almost $2 million in funding. She has received multiple awards for her impact on rare disease education across the country, and we are so excited that she came here to Pediatric to talk with us.
Yes, so thankful for her time, so excited to share this message with our listeners. Let's get right to the content.
Dr. Deb Regier, we are so excited to be recording with you today. We've given your formal intro up top, but please tell our guests who you are, and then feel free to include something that you enjoy outside of medicine.
So fun to be with all of you. So I am Deb Regier. I am a pediatric geneticist. So all my grandmothers and relatives ask me, what do I do for a living? I'm actually the doctor behind the Band-Aid on every baby that leaves the hospital. If you remember, every baby in the U.S. gets a newborn screen, and there's that irritating Band-Aid on every baby's foot. So I'm responsible for helping you first get the Band-Aid off the foot, and I can give you all the tricks of how to do it. And then second, I'm the doctor on the other side of that result, thinking about what does this mean for this family? Is it a false positive, a false negative? What are we going to do with this information? So that's what I do for a living. I take care of kids with inborn errors of metabolism. Now, what do I do for fun? So I love doing really strange crafts. So I used to do glass fusion, but during COVID, all my glass fusion centers closed. So now I do something called quilling, because it's just paper and glue. So if you come over and meet me, you'll see quilling of DNA pathways, metabolic pathways made out of paper that is glued together. So come visit here at Children's National, and I'll show you random craft projects I do nights and weekends. How's that?
Oh, that is
I'm really
awesome.
exciting, huh?
So fascinating.
It took me a minute, but I do know what quilling is. That is awesome.
Yes, you can all Google it if you don't.
That's right.
Yes.
We'll leave it in the show notes.
There you go.
So tell us, how did you become interested and end up becoming a geneticist?
Yeah, so I was actually a lipid biochemist, and I did research for 10 years before I went back to med school. And I had taught the biochem class for med students. And then I had to take the class I had taught the year before. So the poor person teaching the class was like, why are you here? Go do something else. So I went and I shadowed. I was supposed to be shadowing pediatric endocrine. They forgot to tell me they canceled the clinic. So I ended up in a metabolic clinic. And that was my first time really realizing what a metabolic physician does. And I fell in love that day. I loved caring for patients. I love implementing metabolic pathways. To be blunt, I'm one of those nerdy people that thinks in pathways and chemicals and biochem, and I love all that stuff. So to have the opportunity to actually use what I love and apply it in patients and have the pathophysiology behind what we do and why, and how knowing pathways can implement how we save lives is really cool to me. So that's why I do it.
That's beautiful. What recommendations do you have for someone who's maybe a pediatric trainee or an early critical care physician who really wants to make a positive impact on their division's approach to genetics and metabolism?
I think that the first thing to do is anytime we think about genetics and metabolism, we're always taught when you hear hoofbeats, think horses and not zebras. And I think on one hand, that's true, but you have to remember there's now 8,000 rare diseases. So we need, especially in pediatric medicine, to always think, yes, we have to think about the horses, but we have to have a zebra in the top 10 of our differential, because otherwise we're going to miss things that are really important. All of the kids don't come into the ICU and into the hospital. Most kids never make it into our doors. But if you look at the kids admitted to hospitals, the number of those individuals with a rare disease is exceedingly high. So just the fact that they entered our door, they deserve a zebra diagnosis in their top 10. So I think that's something that I always want people to think of. Always has to be on the differential. It doesn't have to be the answer, but it has to be on your differential every time in a pediatric patient.
Definitely appreciate the wise words. Before we jump into today's topic, any relevant conflicts of interest to disclose?
Yes. So I do have funding both from NIH as well as pharmaceutical companies for my educational work. So I create educational products to help people of all levels of training better understand genetics and metabolism.
Excellent. Dr. Regier, usually on PedsCrit, we take a patient approach.
Mm-hmm.
But today we are taking a pathway approach.
Because you heard me. I love me a pathway. Yes.
I know you love pathways.
I love pathways. It's so fun to think about pathways. I know I'm such a nerd, but that's okay.
No, that's the point. That's why we're here.
Yeah.
Let's start with the TCA cycle.
Oh, so remember back to high school biology. I think they now teach this in 3rd or 4th grade. I don't know. I think it's no longer high school. It's like infancy. They're teaching TCA cycle. So we all remember that the TCA cycle and glycolysis, you take your glucose, it goes through glycolysis, it becomes lactate and pyruvate, and then pyruvate goes into the TCA cycle and you make FADH2 and NADH. And now like 90% of you are already asleep. I realize this, but that's okay. The reason I bring up these pathways is if you think about fetal life, what do they actually really good at doing? They're really good at taking glucose and turning it into energy. Most of the amino acids and the fats that get transferred through the placenta are actually used for growth. That's how you get the fetus to grow. The energy is coming through glycolysis, the TCA cycle. And that's why, kind of at the base, I always remind people we have to think about those pathways, because if you understand those, you know what almost every human that was ever born at some point in their life had the ability to do. So it really helps us to think about, in an emergency, what are some assumptions we can make about individuals' metabolism. You were born able to use glucose. Now, you could lose that ability, but you were born with that ability. So really thinking and remembering glycolysis and the TCA cycle gives you that basis of what is the basics of every infant that's born had the ability to do at some point. So when we think about the TCA cycle, the next step is called the electron transport chain. So again, people are having flashbacks. You might be stressed out now. Sorry about that. But just remember, the electron transport chain, this is taking place in the mitochondria, and it's where we convert our oxygen, take those electrons, and then the oxygen becomes CO2, and in that process, you get ATP. Without ATP, you don't survive. So to be honest, in the middle of the night, when someone calls me and saying, what do I need to do to keep this child alive? I always kind of reply back, well, you got to make sure they get ATP. How are you going to get them some ATP? Well, we were all born with the ability to turn glucose into ATP. So until proven otherwise, I'm going to tell you this mantra that everyone knows, D10, normal saline at 1.5 times maintenance. Where the heck does that mantra come from? It's that if we give a glucose infusion rate that we know can push glycolysis in the TCA cycle and electron transport chain, then I know that you should be able to have enough ATP to survive the night. And we'll worry about everything else in the morning. So when we think about glycolysis, TCA cycle, electron transport chain, I'm not so worried that all of us know all the nitty-gritty details. We just need to remember we push through those pathways most of the time. Now, Alice and Zach, we got to think about what are the exceptions to this rule, because, man, I think all of PICU is the exception to the rule, right? So some of the exceptions that I always kind of think about in the back of my head is, what if they have a mitochondrial disease where they can't use the electron transport chain because, they have a component that's abnormal, or maybe they're missing a step in the TCA cycle, or maybe they have long-term mitochondrial damage and their entire mitochondria is damaged. What do we do then? Well, then we have to really think about what can they do? And we're going to give them what they can use and don't give them what they can't use. It seems so simple, but in the middle of the night, sometimes it's hard to remember. So, for example, I might say, okay, I'm going to have you start D10 normal saline at 1.5 times maintenance. And sometimes if I think they might have a mitochondrial disease, I might have you call me in 2 or 3 hours and tell me, hey, what's the lactate level? Because if your lactate level is worse when you start dextrose, then I'm worried that you can't push the pyruvate into the TCA cycle. I'm worried you might have an issue with your TCA cycle or your electron transport chain. And then I'm going to have you back off on the dextrosing and give other sources of energy. So I always feel like this is a conversation that keeps going with your metabolism consult that you have. So that's kind of that one exception is if you're doing everything right and your lactate's getting worse, ooh, maybe they can't use the glucose pathway as well. And that would be your evidence that it's not going well, is that lactate bumping up in an unexpected way. Now, let's be honest, they had some anoxic injury, it's going to go up. If you're flushing because you're giving all that fluid, you're going to flush the lactate. But if it's outside what you would expect or what you've seen in other patients, that's when you're like, maybe this is the mitochondria telling me I'm stressed.
Nice.
I've also seen other labs like lactate to pyruvate ratio or even alanine. Will you help me understand what those are used for?
Oh, yes. Okay. So let's go back a step. So I always think, what can I get the PICU to get me at bedside? Because I know y'all want to know what we're doing and have an answer within 25 seconds. So I need a point of care ability for you. And that's why the lactate is so helpful in that overnight, what are we doing right now? You can get lactate on a point of care. Now, if I can get a lactate to pyruvate ratio, it can be really helpful to tell me your ratio between the two, how well I'm pushing things into the TCA cycle. But I also know that we are at risk of that lab taking days to weeks to come back. I don't have days to weeks to make this decision. So instead, what I'm going to do, if it's going to take a few weeks to come back, I don't have time for that. Depending on your institution, you might have the luxury of plasma amino acids being done really quickly. In that case, you can actually look at an alanine level. Lactate can be converted to alanine when there's excess lactate in the cell. So by looking at an elevation of alanine, it's kind of like the hemoglobin A1C for lactate. It gives you a picture of what's my lactate been, not just at that moment in time like you would get on a point of care lactate, but what's my lactate been, in the hours to days before that lab. Again, depending on your institution, it might take you 2 or 3 weeks to get an alanine back. So that might not be helpful. But if you happen to be at someplace with an in-house lab, you could get it back the next day. And that would be really helpful. Now, we also know that lactates are really hard to draw. So if you're drawing a lactate and you're having to put it on ice and send it down to the lab, it's really easy to have a spurious lactate level. The number of times I'm on call and I get called from an outside ED, this adult ED person didn't know, they ordered a lactate, this baby's lactate's high. Do we have to admit them? What do we do? It's just so stressful because your risk of false positives is so high. So that's why alanine can be really helpful to kind of figure that out for you.
So neonates or in fetal development, we're getting our ATP from the TCA cycle. We're using our lipids and proteins for growth.
Mostly, yeah. I mean, not 100%, but that's a good assumption. Yeah.
Nice. So to get to birth, that system has to be working well. And then when you get to the stage of, I have an undifferentiated sick, maybe failing to thrive, neonate, infant, small child, and I've got maybe a bump in the lactate, I can think critically about the TCA cycle and is it working well? How high is my lactate? What's my lactate to pyruvate ratio? And then if I have an alanine, is this someone who's had sort of a chronically elevated lactate for a while?
Yeah, exactly. And again, we have to have a backup because lactates are so hard to get a good level on them, especially in a neonate. They have to be free-flowing. They can't be tourniqueted. Outside hospitals, really, to be blunt, it's so hard to draw blood on a baby anyway.
Yes.
So we really can't have an expectation that an outside hospital can get a reasonable lactate level that's reliable. It's just not fair to them. They can't do that.
Yeah. Oh gosh. I never even thought about the way that a baby that looks bad with an elevated lactate, I'm talking to them. And then if they look good and they have an elevated lactate, you're talking to them probably all the time.
Yes. Yes.
All right. So that's our basic glucose metabolism, right?
Mm-hmm.
What about fats and proteins and the other things that we turn into ATP?
Exactly. So let's think about it. This morning for breakfast, I had an egg. So I didn't have any carbohydrates and I survived for hours and hours on an egg. That's because humans are able to take fat and protein and turn it into ATP as well. So let's think about if you can do that well. First of all, it's a backup for the glucose pathway. And also, if you can't do it well, it can lead to both not having enough ATP if you can't do it well, but even more often, you can have accumulation of toxic intermediates. So if you think about in the glucose pathway, we talked about build up lactate and that's acidosis and that's bad. It's an acid, but you don't have ATP. Plus you have something negative building up. In the amino acid breakdown, we're going to talk a lot about toxic components that build up. And it's those buildups that really cause the problem. But it's also that secondary, you don't have enough ATP. And then when we talk about fats, We're going to talk about a little bit of buildup of components, but a lot of ATP issues. So that's what we're going to kind of go through. So I'm going to start with proteins. So remember back, proteins are like a bead on a string of amino acids. And when you eat a protein, your body breaks down those proteins into the amino acids. Once the amino acids make it into your cell, it's within the mitochondria that you take those amino acids and you convert them to energy. So how exactly do you do that? Again, this is one of those things you either have a very positive recollection of this or you're like, oh, I'm ready to hide under my pillow because I have like flashbacks. It's really simple. Just remember amino acid. The amino group gets converted to ammonia, and then ammonia is floor cleaner. So if you build up ammonia, it is toxic. You do not need floor cleaner in your brain. And ammonia actually has 6 different mechanisms that it causes brain swelling. So when someone tells me, oh, the ammonia is a little high, and I said, so by definition, you just told me they have cerebral edema. And they're like, no, I said the ammonia is high. And I said, yeah, and I'm telling you, they have cerebral edema if the ammonia is high. It is what it does. It is what it is. So when we think about any child out there, if you get a call with a high ammonia, by definition, you have to make the assumption that they have acute or acute on chronic cerebral edema at that moment. It is always a medical emergency until proven otherwise. But again, like we talked about with the lactate, it can be pretty hard to get a reliable ammonia level. But even with the worst blood draw, someone who's never drawn a child's blood sample, everything went bad, nothing was done right, I'll only give you 50-point credit for a bad blood draw. So if you're telling me the ammonia is 300 and the normal is 50, that is still a metabolic emergency. If you're telling me it's 100 and normal is 50, okay, well, how bad was the blood draw? Oh, okay, it was a hot mess. Mom's like, man, they were the worst blood draw ever. There was no ice even in the vicinity. Okay, I'll give you 50 points, but I won't give you more than that, to be blunt, because it has to be viewed as the metabolic emergency it is. So when we get that ammonia, we are supposed to take ammonia and put it through the urea cycle. Now, remember, urea cycle's job is you take ammonia, it goes through the first steps, CPS1, OTC, you're having flashbacks to all these letters. It goes through the bottom of the cycle, that's a circle. It goes through citrullinemia, arginine, all of these intermediates. And then what is produced is urea. So if you think about it, we take ammonia and we take those nitrogens from the amino acids. They get converted through the urea cycle into urea that has that nitrogen group, and then you pee out that nitrogen. So it's a way of taking that nitrogen group from the amino acid and excreting it. If I can't do that process, so if I have CPS1, if I have OTC, if I have citrullinemia, if I have arginase, in each of those cases, my biggest risk at that moment in time is buildup of ammonia. So to be blunt, in the ICU, you don't really care which urea cycle defect they have. Mm-hmm. That's for tomorrow morning.
You said it. I didn't say it.
That's for tomorrow morning, right? Tomorrow morning, we'll figure out which one. Today, in the middle of the night, we just need to have a high index of suspicion to check for an ammonia level. And then if it's high, to identify how do we get that ammonia level down. Yes. So that's what we have to think about in that acute setting. Now, I'm going to flip it over. Maybe they come in with a diagnosis of a urea cycle disorder. And the flip side is the same. You have to be thinking, do they have hyperammonemia? And if so, how high? So if you think about that side of things, that, a kid coming in with a known diagnosis that leads to a risk of hyperammonemia, well, what do I want to do for that kid? Let's think. If I'm building up ammonia because I'm breaking down amino acids to turn them into energy, well, what I want to do is I want to stop having them turn amino acids into energy. I know this seems so logical because it is. So what am I going to give them? I'm going to give them what they can use. I'm going to give them glucose. I'm going to give them that glucose infusion rate, that D10, normal saline, 1.5 times maintenance, that GIR of between 5 and 10 to push through the glycolysis and the TCA cycle. I'm also going to give them fat if they can use it. So remember, you might not be able to use amino acids for energy, but you can use fat for energy. So I can give you, intralipids or SMOF or whatever your institution has. You can do that through the IV. So as we think about giving them what they can use and not giving them what they can't use is key in managing a kid with urea cycle disorder. The other caveat to urea cycle disorder kids is when you go into starvation mode. So that is every vomiting kid. Let's think about a kid who vomits at home. They're all in starvation mode, dude. That's by definition what children do. When they're vomiting, they're in starvation. But if you happen to have a urea cycle disorder, you have to come in right away because if you're vomiting at home, you start breaking down your fat and muscle for energy. What happens if a kid with a urea cycle disorder comes in and is breaking down their fat and muscle for energy? Guess what? You just fed them a steak. Their own leg is a steak. And suddenly you have this completely uncontrolled amount of amino acids that just got dumped into their system that they're trying to now to turn into energy. So, okay, I'm a kind of a control freak when it comes to my metabolic patients. If they are eating their own muscle for energy, I have no control about how many amino acids they're getting and their protein content. So I want to take control back. So I want them to stop catabolism. And that's also why I'm going to give lots of sugar and lots of fat, things they can use, and not give them things they can't use, which is breaking down their own muscle for energy. So that's why it's so important that we control catabolism in that overnight important, emergency kind of situation. Okay, so all of that just talk about the amino group. Whew, exhausting, isn't it? But it's so cool.
So if you can't run your urea cycle and you've got CPS1 or OTC or citrullinemia or something like that, and you're coming in undifferentiated, can you speak to... I've seen in a couple of these kids, they come in and their BUN is low because they can't make the blood urea nitrogen.
That's
and then
right.
As we treat them, it slowly comes up. Can you speak to that a little bit?
So if any child comes in dehydrated and has a low BUN, they are mine until proven otherwise, right? Because why? When you're dehydrated, you're supposed to have a high BUN, right? You're supposed to have a little bit of I'll call it kidney sluggishness, but you should have a BUN bump if you're dehydrated. And if you don't, I'm like, ooh, could you be mine? Do you belong to me? Again, if you start seeing that you're doing everything right and that BUN starts to bump up, I don't usually see kids with urea cycle disorders that have a normal BUN. Often they remain on the low side of normal at most because they never get all the way kind of filled back up. It never completely works. I do want to mention, I'll mention here, I guess, a little bit about what do we actually do for high ammonia levels?
Yes.
There's a couple different things you can do. The first thing is you can dialyze off the ammonia. So in an emergency situation, if you have access to CRRT type dialysis, that is considered kind of gold standard for treating hyperammonemia. But I don't know about y'all. I don't really want to put every child that comes in through dialysis every time they come in vomiting. Really not reasonable. So there's been 2 medications that have been developed that can reduce your nitrogen load. Now, we call them ammonia scavengers because we're lazy, just full disclosure. What they really do is they make nitrogen groups water soluble so you can urinate them out. So you're just reducing your total nitrogen load. There are individual medications that are orally available. So often kids will come in on sodium phenylbutyrate or Ravicti or sodium benzoate. Those are our what we call ammonia scavengers or nitrogen scavengers. When they come in acutely ill, we often need to switch over to a IV formulation. So there is an IV formulation. It's called Ammonol. And often we will run a bolus over 2 hours. And then that same dose is given additionally over 24 hours. So if you have a really high ammonia level, you're trying to get it down quickly, that's why we give Ammonol. Or if you come in and you really can't tolerate the oral medications, you might have to be on Ammonol because you can't do orals. So that's the mechanism for that.
As an outpatient, do these children typically maintain these oral meds daily, or are they more of like a sick medication?
Most kids with urea cycle are going to be on a daily scavenger, and it's given either 2 or 3 times a day.
And then how significant is the ammonia decrease with Ammonol on an inpatient basis?
Yeah. So let's imagine that you come in encephalopathic. If you have a urea cycle disorder, if you're somewhere above 300 for an ammonia level, you're going to probably have some encephalopathy. Above 500, you're probably going to need intubation because the mental status changes. And I would say starting Ammonol, depending on the child, of course, this is a guesstimation, I would say you can drop anywhere from 1 to 200 ammonia points, the bolus. And really our goal is to get back down to within 50 points of their baseline within 24 hours.
Yeah.
If I start Ammonol and I don't get a good response within even the first 4 to 8 hours, I'm still thinking dialysis.
Yeah.
If you're encephalopathic to the point that you have to be intubated, your mental status is requiring intubation, I am probably starting Ammonol while calling for dialysis with the hope that I get to cancel the dialysis. Now, if these kids are at an outside hospital that does not have access to dialysis, this is an urgent transfer. Even more important, Ammonol is an ultra expensive medication and is not in many rural or regional hospitals. So they may not have access to Ammonol. If that's a situation going on and they have an oral medication, that's when we hope to goodness that they have a G-tube and we're putting some Zofran in that G-tube. We're starting putting that med through that G-tube until we can get a helicopter to them. Depending on your state and your system, you might even fly with Ammonol if it's an acutely urgent thing, and then you're flying with the Ammonol so it can be given en route, depending on your state guidelines and if that can be done there.
Nice.
Yeah, so quaternary centers are going to have Ammonol, some tertiary centers, and then pretty much within flight of every birth hospital, you need to have Ammonol because of a metabolic emergency. But not every hospital has Ammonol. It's too expensive to store for everyone.
Sure.
Oh, wow. All right. So we're breaking down proteins. We've taken the amino group, made it into ammonia. We've talked about if you can't deal with that.
Okay, so we talked about the amino side of amino acids. Let's talk about the acid side of amino acids. So if we think about the acid side, these are what we're now going to call the organic acid disorders. So remember, amino acids just have an amino group, an acid side chain, and then have carbons in the middle. So they're called organic acids because everything with carbons is called organic in biochem. Having flashbacks again, I know all of you, that's okay. So these organic acids are all different depending on what amino acid they came from. So you have whole groups of amino acids that now have to go through some pathway. So we have multiple pathways that convert these organic acids, this other half of the amino acid group, and they all get converted through different pathways, and the end product are intermediates of the TCA cycle. And I just find that to be so cool and so elegant and just so amazing. That's how we get energy from our amino acids. The acid side of it goes through different pathways depending on the amino acid, gets dumped into the TCA cycle, and voila, you get ATP out of it. So when we think about some of those pathways, some of the ones that I think about all the time, one pathway we nickname the vomit pathway. It's for valine, ornithine, methionine, isoleucine, and threonine. And I call it the vomit pathway because guess what you like to do if you have buildup of those organic acids? You like to vomit. Two of the disorders in that pathway are propionic acidemia and methylmalonic acidemia. Those are frequent flyers in a PICU. The reason that is these kids get acidosis because it builds up acid, but they also have this nasty second thing that happens. Propionic acid and methylmalonic acid block the first step of the urea cycle. So not only do you now have acidosis, you also have the infamous hyperammonemia. It's a buy one, get one free group of disorders. And because of that, these kids can look a ton like a urea cycle kid, especially as newborns or if it's an undiagnosed patient. They're going to present with hyperammonemia. That's the main thing. That's what's going to get them into the ICU. And then you're trying to figure out, do they have a urea cycle disorder? Or do they have an organic acidemia disorder? Good thing we have pHs on every point of care machine we have, right? So often your pH can give you a hint if they're very acidotic. That gives you a hint that you might be dealing with an organic acidemia disorder. If we think about other pathways that are involved in breaking down organic acids, one of the other pathways breaks down lysine, another one of our amino acids. The intermediate in that pathway is glutaric acidemia. So glutaric acid builds up, and you might have flashbacks to GA1 or glutaric acid, and that can lead to other types of brain abnormalities. This is considered a neuroorganic acidemia. It can lead to brain bleeds. It can lead to basal ganglia strokes. So these are kids that come in with an acute or chronic stroke picture. So that is kind of a really important thing. I always tell people, little kids should never have a stroke. This sounds really negative, but I'm just going to say it because you'll remember old people that have had bad lifetime habits, they get strokes. Little kids should not have strokes. So if a small child is coming with a stroke, you always need to have your organic acidemias on that list. And you're going to want to have anything with a high ammonia on that list because hyperammonemia can look a lot like a stroke because of that encephalopathy that can come along with a stroke. So how do we treat organic acidemias? Well, guess what? Don't break down your amino acids. Shocking, I know. That's the first thing. So we're going to say, let's feed glycolysis, feed fatty acid metabolism so I can get energy that way. So I'm going to try to decrease my catabolism. Second thing I'm going to do is you might need to treat the acidosis. This is one group of kids that we actually give bicarb to if they need it in the ICU setting. A lot of ICUs don't love bicarb, but if I know you have a reason to need it, we're going to try it. The third thing we might do is we might give something called carnitine. So carnitine is this lovely, amazing molecule. It is very promiscuous. It will bind to any carbon chain, bind to that carbon chain, and either take that carbon chain into the mitochondria to turn it into energy, or take that carbon chain, make it water soluble so you can pee it out. So if you have high amounts of any organic acid, the carnitine can bind to it, make it water soluble, and reduce a bit how much you have and leads to increased excretion of that acid. The third thing I can do to treat this is if you have the hyperammonemia because of the MMA or the PA, the methylmalonic acid or the propionic acid, we now have a medication that was just FDA approved last year that competes to activate the first step of the urea cycle while the MMA and PA are inhibiting the first step of the urea cycle. So we're trying to overcome that inhibition.
Wow.
So it's called Carbaglu. Again, all these meds are incredibly expensive, and Carbaglu is only available at certain quaternary treatment centers, but it has been shown to reduce your hyperammonemia in that situation and has reduced hospital stays. So that's why it's now FDA approved. So that's what I'm going to do if I have a kid with an organic acidemia.
So diagnostically, seeing this fingerprint of severe anion gap metabolic acidosis and hyperammonemia, is that relatively specific, in the absence of lactic acidosis, is that relatively specific for these organic acidemias?
It is incredibly specific. And the way you would do the confirmatory testing is you would send something called urine organic acids, and then they would actually look for that methylmalonic acid, the glutaric acid, the isovaleric acid, all of these different intermediary steps. So the definitive diagnostic test is urine organic acids. But acidosis in a kid with hyperammonemia, we're kind of going down that pathway pretty quickly, or at least thinking that we should be thinking about that.
Yes. Correct me if I'm wrong, this glutaric acidemia, this is one that might be confused with maybe a victim of trauma, correct?
Yeah. So there's this folklore of kids coming in with GA1 that were thought to be child abuse that then ended up being GA1. I will remind people that you can have GA1 and be abused. Every rare disease, actually having a rare disease increases your risk of being abused. So true and unrelated happens. But at the same time, we always want to think about it. If you have a child who has a brain bleed, but they have no other signs of trauma or no other signs of abuse, it should be on your differential, right? So it should be in the top 10 of your differential. But non-accidental trauma also has to be on that differential. And really think about thinking outside the box and always keeping GA1 on there.
Nice. That's one of my questions as well, is the GA1 stroke, is it hemorrhage usually, or is it like an anoxia to the basal, like a hypoxic injury?
So you can get bridging veins pull because these kids tend to have macrocephaly, but their brain does not grow as much as their skull, so they can get bridging vein bleeds. So they can have that type of brain bleed. The type of stroke we usually see in GA1 are basal ganglia strokes. So, and again, they're not blood clot strokes like you would see with other disorders. Instead, they're metabolic strokes where that area of the brain didn't have energy. So they look a little bit different. And GA1 has very unique MRI findings. So if you ever are like, is this non-accidental trauma? Is this GA1? Really having a good neuroradiologist that has seen both look at the imaging can be really helpful and really important.
Oh, nice. Thank you. Especially because, the basal ganglia is going to take the first hit even in just a classic anoxic injury.
Right. So you have to have that expert that's seen 100 of each in their lifetime.
Great. Anything else for protein metabolism?
So let's talk a little bit about how different proteins interconvert to other proteins. So that is a whole kind of other group of disorders. So probably the most famous one is PKU, phenylketonuria. Now, to be blunt, if they're showing up in your ICU, it's because they were out living their best life and had a car accident or some other horrendous event. They should not be admitted to your PICU because of PKU. That just doesn't happen. But it is kind of the pathognomonic inborn era metabolism because it's where newborn screening started. We'll talk about that in a little while.
Mm-hmm.
The other kind of two disorders I want to mention, the first is homocystinuria. So homocystinuria is a disorder where you can't convert your tyrosine. You can't get through the tyrosine pathway and you have buildup of homocysteine. Now, if you remember, homocysteine leads to increased coagulation. So that's when you're going to get that stroke that is like a coagulopathy type stroke. So that's homocystinuria until proven otherwise in my head. And I always say, if I get consulted of a kid who had a stroke that was young, I'm like, well, what's a homocysteine level? And they're like, oh, I don't know. And I'm like, well, then why didn't you look? You got to check a homocysteine level in any child who has an unexplained stroke, in my personal opinion. The other thing that is a common presenter in the PICU is another reason for brain swelling, and that is elevated leucine levels. So elevated leucine levels happen when you have an abnormality in the breakdown of 3 amino acids, isoleucine, leucine, and valine. Those are your branch chain amino acids. And I will give you my cheesy mnemonic of I love Vermont, because that is what causes maple syrup urine disease. So ILV, maple syrup urine disease. This is named because their urine can smell like burnt sugar. Sometimes it smells like maple syrup, but more like burnt sugar. And it's because of an accumulation of those keto acids. So what leucine does is it actually crosses the blood-brain barrier and causes cerebral edema, similar to how ammonia does it. So I always say, if you have a newborn and they are encephalopathic, the two things that have to be on your thought is, yes, check that ammonia level, but could this be elevated leucine? So those are the two things you always want for that baby with brain edema. Now, if you have maple syrup urine disease, I can't give you an ammonia scavenger. It's not going to help you. It doesn't help get your leucine down. There's only two ways to get leucine down. One, dialysis. But again, who wants to put a newborn through dialysis if I don't have to? And number two, you have to grow into your leucine level. So you actually have to take your leucine, your isoleucine and your valine, put it together and make it into protein. So for example, just last week, I flew a baby from another state here to my hospital because of a new diagnosis of maple syrup urine disease. And like I told my poor NICU, I was like, okay, we're going to watch this baby grow in front of us, literally. We poured almost twice the number of calories, twice the amount of liquid that any other baby would need. This baby literally got round in front of us. Wow. And that's how we got the leucine down. We actually get them to grow into their leucine. So maple syrup urine disease, we always have to think about. Now, technically, maple syrup urine disease is on the newborn screen, but there are some populations where it can be missed on the newborn screen. And sadly, it is our highest risk populations. People from Central America are known to be missed on the newborn screen. And that's often a patient population that they don't always have access to great care. So if a baby dies and no one knows why, sometimes that's because of maple syrup urine disease likely in that patient population. So I always bring that up, that especially families from Central America, if I hear, hey, there's an encephalopathic baby, you hate to be the one to ask it, but I'm like, are they happen to be from El Salvador, Guatemala, or Ecuador? Because if they are, I want them flown to me so we can take care of them.
Is that a specific genetic mutation that's not capturable?
There is. There's actually 2 genetic mutations in that patient population that seem to put them at higher risk for later onset. So they have onset between 1 and 2 weeks of life instead of 2 to 3 days of life. Wow. So they're often missed by the kind of high risk people that are thinking about it.
The 24 hours after the first feed isn't long enough for them.
It's not long enough. Yeah.
That is, Deb, I'm reflecting now on the last time we had this conversation. I was a Gen Peds resident and I was sending the leucine level and following it up. But now we dialyze kids all the time. Do you think it's fair to say that if someone rolls in altered with maple syrup urine disease and you're doing the Q&R neurochecks, you're a little bit worried about them, maybe you've scanned them, maybe they're intubated, is it safe to say that you should just initiate dialysis as fast as possible?
So my policy on when do I initiate dialysis is if they have to be intubated for mental status change, they are getting dialyzed.
Yeah.
So that's kind of my thought is if your brain swelling is to that point, I'm done. I'm not waiting. Now, if I have a newborn come in and they're kind of eating, they're still crying, they're still responsive, I'm going to try to feed them. But if in 4 hours they're not better, I'm calling dialysis, right? So similar to hyperammonemia, at any moment in time, you're going to have this, okay, every minute every hour I'm reassessing. If it's not going the way I wanted to, I'm calling it. We're going to dialysis. It's always the gold standard if you don't know what else to do.
Yeah.
It's also why it's so important to get to a center that can do all of these things quickly. So if there's a baby at a non-tertiary or non-quaternary hospital, you've got to move these kids to some place that can do it. Sometimes they're going to have to stabilize there, especially if they have brain swelling. They might not be able to move until they're stabilized. But you've really got to really think about where's the safest place for this child and how do we get them to where they need to be.
Oh, absolutely. I also have to ask, has our Aquadex rollout changed the dialysis you've been able to do in the neonates? It's a personal question I can ask later too.
I have no idea.
Okay.
Do you love me? I'm like, I don't know.
Okay, well, that's
I'm not
good,
a
because that means that
nephrologist.
it's not a problem for your patients.
Alice,
I'm not a nephrologist. I don't know. I would say our dialysis is safer now than ever before. If we were to go back 15 years ago when I was in training, our risk of death from going into dialysis was actually decently high. I don't know the last time I've heard about a death during dialysis.
Mm-hmm. The circuits are getting better. It's a little...
the circuits are getting better, especially the circuits for small babies are getting better. There's a couple of centers that go straight to, they don't even go to CRT, they just go to bypass. They go to ECMO because their center is...
The only way to dialyze a really tiny baby sometimes, right?
Right. So they just go straight to ECMO because their center is so competent at ECMO. So there is some level of knowing your center, knowing what your center's best at. So again, I'm kind of talking generalities here, but really you got to know what your center, how they manage it and how they approach things.
Oh, absolutely. Really changes your whole framework, thinking about the world of which infants can I dialyze. But
yeah, exactly. And how and when.
And Alice, comment about Aquadex, probably similar to you guys. We have Prismax CRT, Aquadex, and Carpe Diem. I'm not sure if Aquadex gives you clearance. It might just give you just fluid removal. It's an ongoing conversation. Which one does what?
We need a nephrologist. I don't know.
Yeah, no.
That's right. Deb, I have another question. We see patients in the ICU with intracranial hypertension, cerebral edema for a number of reasons. And, especially thinking in the trauma population, it's very common standard of care to give hyperosmolar therapy, mannitol, hypertonic saline. Do you find in these metabolic patients using hyperosmolar therapies are helpful or not necessarily?
Great question. I'm glad you brought it up. So we are pretty aggressive at keeping our sodiums on the high side of normal. So we want to keep it above 140, often above 145 if we can in our kids while we're stabilizing. Especially with maple syrup urine disease, these kids seem to sodium waste. We can have a brand new baby that's on D10 normal saline as a neonate. And that's how I keep that sodium high. So you're really pushing much higher sodiums than you would expect. And you might have to go to some centers called hot salts, some centers called hyper, whatever you call it at your center. Lots of sodium. So pretty much standard of care is you give normal saline until proven otherwise. So there are some centers that are still doing D5 half normal at 2 times maintenance. Their idea being, hey, we need volume. Our center happens to use normal saline because of some of the literature coming out of our center and others looking at normal saline levels.
Sodium levels, hyponatremia.
Yeah. The other thing to think about is, I'll just throw this in while we're kind of talking about fluids. We would consider lactated ringers to be contraindicated in someone who may have some type of metabolic or genetic syndrome until proven what they have. So if you think about lactated ringers, you're using lactate as a form of energy. So if you don't know for sure what you're able to do, how your mitochondria is functioning, how you are dealing with your acidosis, we would not recommend you use lactated ringers. So that is why often, depending on your center, at our center, we actually make lactated ringers an allergy or a contraindicated fluid on kids before they go to the OR so that no one gives it accidentally.
Yes.
So that's one thing that's anti-standard of care. The other thing that's a little bit anti-standard of care that we see, especially in kids who have amino acid disorders and urea cycle disorders, is being very careful if you're using systemic steroids. If you think about it, one of the things systemic steroids does is it activates catabolism. So if you're increasing your metabolic demand significantly from your systemic steroids, it's not that you can't do it. If they're life-saving, you're going to do it. But we need to know so that we can increase the glucose infusion rate, so we can increase the calories, all of those things. If it's given, I feel like every time you guys want to extubate someone, you want to give systemic steroids. And I'm like,
Sure do.
Do you really have to? How many days do you have to give? How many doses? I'm all over it. And if you tell me you're going to do it, I will increase all their calories by 10 to 20%. I'm going to watch their leucine levels closely. I'm going to watch their ammonia levels closely. We're going to have to do all those things. But just thinking about steroids willy-nilly is not okay with me. Not that you shouldn't do it. We just need to know you're doing it to know what we're going to have to manage on the back end.
Another question about fluid and electrolytes. I'd say locally there's generally a shift away from normal saline towards buffered solutions.
Yeah.
Because of all the hyperchloremic acidosis we see and maybe some of the suggestive evidence about kidney outcomes not being as good with saline. Plasma-Lyte gets used a lot. That's a brand name. It's like another balanced solution using acetate and gluconate.
I love that you're asking this. We don't know yet. That has not been studied in metabolic patients. We don't have a good answer. And I actually took it to my whole division to ask that question. I don't have a good answer. This sounds crazy, but we're going to take it to the metabolic meeting, the Society of Inherited Metabolic Disorders. Put every metabolism person in the country in one room, and we're going to ask them the question at our meeting in spring because we don't know. So we're actually proposing that as one of our what would you do questions this year because we're not sure what to do with it. We don't know if it's a good idea or a bad idea, but by kind of using groupthink of what are the risks, what are the benefits, maybe we can figure that out. That's why we came out with we don't recommend lactated ringers because we felt like there was too many risks to replace normal saline that didn't have the risks. So I don't know what to tell you yet, Zach, but we'll get back to you when I can figure this out. Again, there's no studies. Right? There's no clinical studies, but really it's going to be a matter of having a lot of people who think a lot about metabolic disorders, thinking about what are the risks, what are the benefits, and then making executive decisions.
Oh, wonderful. Well, if you come back with a consensus statement on Plasma-Lyte, we will be happy to cover it anytime.
Thanks.
Breaking news.
If we can figure this out. Exactly.
Yeah, before we move on, can you speak to the difference? Am I calling these organic acidemias or organic acidurias?
Oh, yeah. You can call them whichever one you want.
Doesn't matter.
Organic acidemias means that you have acidosis in your blood. Acidurias means that you have organic acids in your urine. Most of the time, you're going to have it in both places. That's why you get these names that are going back and forth.
Excellent.
How's that for an answer?
Fantastic.
Yes.
That I'll take. And thank you for listening to this episode of Pete's Crit. Please remember that all content during this episode is intended for informational and educational purposes only. It should not be used as a replacement for medical advice. It's also worth noting that the views expressed during this episode by me, Zach, and our guests are our own and do not reflect the official position of our institutions. If you have any comments, suggestions, or feedback, you can email us at pedscritpodcast@gmail.com. If you want to help support the production of Pete's Crit, you can find us on Venmo and Patreon. We've also had some light merch made in the form of Pete's Crit laptop stickers. And if you include a mailing address with any contribution, we would be so excited to send you one. Thank you again for listening.